All right, we're going to get started, everyone. Welcome to the Frailty and Falls Prevention webinar. Thank you, everyone, for tuning in this morning. My name is Jo Collins, and I'm an Injury Prevention Coordinator here at Injury Matters. So before we get started, I'd just like to acknowledge the traditional owners of the land in which I present from today and in which everyone is dialing in from today, the Whadjuk Noongar people, and extend my acknowledgement to the traditional owners of the land. So before we get started, I do have a little bit of housekeeping to cover. If you've got more than one person in the room with you tuning in today, can you please just send us a quick message via the chat tab and let us know how many people are listening with you. We would also love to hear your questions, so we strongly encourage you to please send them through in the question and answer tab or the chat tab. We will go through them at the very end of the webinar. If you're having any technical difficulties, please use the chat tab and just let Injury Matters know online, flick them a message and we can assist you with any difficulties that you may be having. So today we're going to be having a look at frailty and falls prevention. Just a bit of an overview of what we'll cover today. So we're going to have a look at what frailty looks like in older adults and why it's a risk factor for falls. We're also going to have a look at some assessment strategies and interventions for frailty in older adults. So a little bit about Injury Matters. We're for safer people and places, and Injury Matters aims to prevent and reduce the impact of injury within the WA community. And we do this through advocating and providing education for injury prevention, but as well as also providing support for people that have been impacted by injury. So today's webinar is brought to you through our Stay on Your Feet program with the support of the Department of Health WA. And the Stay on Your Feet program provides information, training and support to older adult community members and professionals working with older adults such as yourselves on how to prevent falls in the community. So this is done through the Move, Improve, Remove campaigns. Move your body, improve your health and remove hazards. Oh, there you go. So falls are a serious public health issue in Western Australia. So every year, 1 in 3 people over the age of 65 will experience a fall. And then this increases into 1 in 2 over the age of 80 years. So on average in WA, a person will die from a fall every 26 hours. They are admitted to hospital for a falls-related injury every 19 minutes. And they'll attend an ED as a result of a fall every 12 minutes. So it's important for practitioners working with older adults to recognise frailty as a risk factor for falls, to assess and to apply interventions. So whether we're carers, support workers, community workers or allied health professionals, we all have such an important role to play in supporting our clients or patients in falls prevention. So to discuss frailty and falls prevention among older adults further, I'd now like to introduce you to our guest presenter, Tony Petta, a senior physiotherapist and falls specialist at Sir Charles Gairdner Hospital and a sessional academic at Curtin University. So Tony has been employed as a senior physio working at Sir Charles Gairdner Hospital Falls Clinic in the Department of Rehabilitation and Aged Care for the last 20 years. His clinical interest predominantly focuses on working with frail elderly people over the age of 65 years within the community and residential aged care setting who are at risk of falls. However, he's engaged in all areas of falls prevention, including inpatients and younger disabled adults at the risk of falls. Tony has a keen interest in teaching and has been involved in tuition to students at the Curtin School of Physiotherapy and Exercise Science in gerontology for over 10 years. He's been a co-author of a number of papers regarding falls prevention initiatives performed in the ED setting. And he has also collaborated with his colleagues at Curtin University in investigating the use of virtual reality as a teaching modality for students and health professionals in the areas of falls and geriatric syndromes for older adults in a community and inpatient setting. So Tony is currently undertaking some preliminary work in the day therapy team at Sir Charles Gairdner Hospital, investigating frailty, tools and falls. So please welcome Tony, and I'll get you to share your screen now.
Hi everybody, good morning. Hopefully everybody can see that. I'm not very tech savvy.
Perfect. That's all good.
Thank you. Thanks, Joanna. Okay, so I've been asked to talk about falls and frailty. So we'll start, and hopefully if there's any questions, I might be able to answer them at the end, or there might be somebody else in the audience who is knowledgeable in the area who might be able to help us. So, firstly, a little quiz for you, which I want you just to be thinking about during the talk, and see if you can establish the link between these three images. I'm not going to give you any more clues other than what you can see on the screen, and we'll come to it at the end. So have a quick snapshot in your mind and see if you can think about potentially what the link is between these three. All right. Fortunately, what we do know is that usually when it comes to falls, it's not often as tragic as this quote does suggest. However, for some clients, potentially this does occur. And in fact, it might actually be that death comes with the first fall. But what we do know is that we're able to intervene when it comes to falls and prevent, hopefully, as many falls as we can. Our frailer clients are more at risk, and the interventions that we use for falls prevention or interventions for frailty, they often overlap very much with interventions for falls. I'm briefly going to overview falls just within a few minutes, then talk about frailty and some related conditions, try to establish the link between falls and frailty, and then just overview some interventions used in this area. So hopefully we all know that falls are an unexpected event which cause a person to land inadvertently on the ground or other lower level. There's many reasons for people falling over. Typically we describe the types of falls as either a medical fall, whether that be a syncopal episode, or a hot fall, which generally in a response to an acute illness. For a frail elderly person, hot falls are actually, they're a marker of kind of like, or a person's response to an acute illness such as a fever might make them more prone to falls. A younger person who gets an acute illness might not so much necessarily fall over, but for some elderly people, often the manifestation of developing a UTI or a chest infection might actually be them presenting with a fall, and it's then that we discover they've actually got an underlying illness. The vast majority of falls, however, that we see generally relate to non-medical falls, or what you could almost term as cold falls, and this is where there's an interaction between the person, environment and activity. So there's lots of individual risk factors that we attribute to an individual. They're working or performing daily activities within their environment or external environment, and the activity becomes critical at the time. So we can often consider it as a compromised body negotiating a complex environment. I won't speak too much on falls data because Joanna's already provided a summary, but just to let you know, just in terms of the scope of the problem, there's approximately 4 million people over the age of 65 in Australia as of the last census. About 30% of those people will fall annually, and that resulted in about 125,000 hospitalised injuries, of which fracture was the most significant injury by far, of about 52%. And that was all types of fracture, not just hip fractures, but also upper limb and lower limb and trunk. approximately a quarter of all injuries come from residential care. So the oldest, frailest population who reside in residential care are actually overrepresented in terms of their injury rates when it comes to falls, particularly because more people live in the community who are aged rather than in residential aged care as well. So there's certain overrepresentation, and it's certainly significantly costly to the Australian economy, and not only to the individual. If we look at what happens with injuries, certainly what we do know, there's a trend towards the older adults. So that we're thinking people to the oldest old, actually having greater rate of hospitalised injuries. And this is pretty significant, even though frailty doesn't necessarily go with age and isn't an inevitable part of ageing. It's certainly more common the older that we get. And hip fractures and head injuries, which are two most significant types of injuries that we see, are certainly more common in our oldest group. I just wanted to put this slide up just to sort of like show in terms of more the mechanism of falls injuries by age. And it's not so much really about this slide, but it's actually about the next, is that there are many reasons for why people fall. And when people come in, they get categorised as having had a trip or a slip, for instance, or fall from another level. And what we can see is that on this graph is as that we go from left to right on the screen, so we go from the younger population to the older group, that falls on the same level from slipping, tripping and stumbling are said to be less common with increasing age. It's also what we do see is we see that the unspecified category increases. So it might be that maybe there's an issue about recall. What's most interesting from a frailty perspective is actually looking at all other causes. So if we look at this graph here, this is looking at that group of all other causes. And what we see is we see a nice kind of like pattern here where this is looking at activities like fall involving bed, fall involving chair, fall on and from steps or stairs, or fall on from a ladder. And what we clearly see, particularly in the top two bars, so a fall involving a bed and a fall involving a chair, so basic fundamental tasks that we need to do to survive and function at home, that it significantly seems to be increasing in the oldest of all group who are more prone to being frail. And I suppose this is really like a cue for intervention for us, that we need to possibly be looking at those basic fundamental tasks for our older population. What it shows is also that these tasks which involve, I always say to my clients, the thing I want you to be able to do most successfully is be able to survive at home. I need you to be able to get in and out of bed safely. I need you to be able to get on and off the chair or on and off the toilet. So what we see is that this is still a huge area of concern, given how these older people are falling. Numerous risk factors for falling, including unsteady walking and balance and muscle weakness. And these are just a couple. And these are certainly often have a lot of focus in falls prevention, particularly because we look at the effect of exercise and how effective that is as an intervention. The mechanisms of injury can often be explained by changes in our balance mechanisms, whether they be proactive balance mechanisms, people fall sideways or fall backwards, and that can result in hip fractures. They might not be able to protect themselves when they have a fall. This interesting study which came out of Canada last year looked at establishing or looking at the falls biomechanics as a risk factor for hip fracture. So they videoed common areas within residential aged care facilities over a number of years, looking at seeing if they could explain how people had a fracture based on how they fell. And it was quite interesting, and is typically we often think about hip fractures being purely like a sideways fall, for instance, but often what they found is that people actually would rotate regardless of whether they actually fell forwards or backwards sometimes, and that rotation then caused them to have an impact on the side which could result in a fracture. So that probably makes or probably kind of like changed my view in terms of how people were actually developing these fractures as well. The other interesting thing that it showed as an aside, that some of the interventions that we often prescribe people, like hip protectors and walking aids, were also slightly protective for some people and had a lower rate of falls in this little video study. Head injury is also a significant issue with falls, and what we do see is that issues such as a lack of protective reactions will predispose people to having head injuries. What's important to note that these balance mechanisms that deteriorate as we go older are often a reflection of declining balance, muscle strength, and frailty. There are other multiple risk factors that we see here, and we won't go into all of them, but these are really key things in terms of explaining people's risk factors for falls. Many of these will intertwine with balance and strength deficits and stuff to create this person at risk. Things like nutritional deficits, which we focus about in falls, is highly relevant to frailty, given the link between malnutrition being a contributor to frailty. Polypharmacy being another issue which is associated with frailty as well. And then some of the other things like dizziness and unsafe environment, these are things which we do also need to consider. Then we have decision making, and the final pathway really is about decision making. So when we're doing an activity, how do we do it? How do we choose to do it? Which might then predispose us to falling, for instance, if we do it the incorrect way, or maybe we perform it in a slightly risky way. Along with this are the things about cognition and cognitive capacity. We do know that dementia and cognitive impairment is associated with a higher risk of falls, but also as our balance and gait deteriorates, we tend to require greater cognitive resources to maintain upright postures, and that potentially might impact or delay our postural responses, which make us more at risk of falling. So my journey in terms of frailty has probably been quite a long one. I've always been interested in frailty, and even though I thought I knew a little bit about it, the reality is I probably know very little, in the sense that as soon as you start reading, you think, crikey, this is a massive area of interest. But pre-COVID, would have been about 2017, 2018, one of the bosses at work said to me, Tony, do you measure grip strength? And I said, yes, but in fact, the way I measured it wasn't actually how he wanted me to measure it. So he was interested in whether I used a handheld dynamometer to measure grip strength. Me, I was really looking at more functional kind of like measures of it. You know, do people have difficulty opening jars and containers at home, particularly their medication containers, carrying, shopping, opening doorways. So I would often look at a more functional kind of like way in terms of how they were using it, as opposed to looking at a formal grip strength measurement. But what I've certainly come to learn about now, in a sense, is that grip strength is associated with a lot of kind of like health markers in the older adult, and certainly things like reduced grip strength during midlife can predict disability in senior years. There's quite a nice review which is down at the bottom of the slide here, which kind of like summarises many of the things that are associated with grip strength. So this kind of like this prompt from the boss at work, who fortunately then actually funded purchasing the grip strength because he wanted me to measure it during certain times, then actually started this journey in terms of learning a little bit more about frailty. So frail is a term which is commonly used. Thanks for assessing this frail elderly lady with. This frail elderly gentleman was assessed, but what does frail actually mean? So certainly I would see referrals with frail elderly lady, or I would write a letter, this frail elderly gentleman. But in terms of being reflective in terms of my practice, what does frail actually mean? So is there a frail stereotype? Potentially, there is certainly a frailty phenotype, which I'll show you or talk about in a minute. But certainly, I used to probably think and go back and reflect that, yeah, maybe this is a frail stereotype. But it might not necessarily be the case, because frailty is more than just physical attributes and appearance. There are lots of other factors which are determinants of frailty, and I think that's probably like the key thing, which is really important to know. So when we think about frailty, we often classify frailty according to, are you frail or are you robust? In between frail and robust, there is often considered to be this pre-frailty or vulnerable period. And after frailty, we actually move from frailty to disabled. And this is a disability in a different sense than somebody who's got an acquired disability from youth, such as a head injury, but this is old age disability. But sometimes appearance doesn't, as we said, appearance doesn't always indicate frailty. No, I'm still quite capable of planting a tree. I'm not sure whether anybody can remember or recall who this is attributed to, but it's attributed to a fairly famous lady who doesn't live here, but she certainly is present. And this is the Queen in July 2019. So physically, if you were just looking at the Queen, you might think, guys, she's fairly petite. She's got quite a significant kyphosis there. She looks physically pretty frail, but there's nothing frail about the Queen. She's quite resilient and she's quite strong. And I suppose it's really about emphasising that frailty is more about the physical characteristics of a person. And then came COVID, and COVID was a really interesting situation, not because it only changed the lives, obviously, of everybody all over the world, but certainly from the elderly perspective. So typically over time, if we look at the pre-COVID state, what usually happens is that we've got individuals within the community, they might have varying degrees of frailty and functional independence. And it might be that, you know, they develop an illness, so they become slightly more frail as they respond and recover from that illness. So that's where we see the good response to casual stresses and the physical trend up in the green in the top half of the slide. Then frailty, then COVID came. And what was the consequence of COVID all over the world, and particularly in many countries in Europe where they've been in lockdown for significant periods, and where a lot of this research has sort of like been coming out of, is that the lockdown was long and significant. And during that time, people became, or there was a risk because people were restricted in being able to perform physical activities, they were isolated in their homes, there was increased physical, psychological and social frailty, functional independence and functional abilities reduced, and frailty increased. And certainly at the time of, and there was potentially issues like falls not necessarily being reported. We certainly had referrals in our clinic during COVID last year, but certainly one of my thoughts was what was going to happen when everybody actually got out and about again, when they were able to go back to exercise and going to the shops and doing all their activities that they normally do. And certainly what was suggested by the authors here is that certainly when lockdown was kind of like reducing it, there was this big potential increase risk of actually more traumatic events, more falls and things. So COVID-19 has been a terrible situation for many elderly, not only in Australia, but certainly in other countries of the world where lockdown has been much longer and much more severe than Australia. And it was terrible from a few perspectives as well, is that we know that the restrictions due to COVID generated a more fragile class of older adults both during COVID, but also at the other end. But the other more frightening thing, and I think which is probably that we saw, is that frailty was often considered in decision-making during acute care at the height of the pandemic due to scarce resource allocation. So that was one of the things that must have been terrible for people, in the sense of thinking, I can't get out of my house, I'm restricted, I can't see my family, I can't do the activities that I would normally do. But then at the back of their mind was there this concept that was coming out, as we saw it on the news and stuff, where people were being left in corridors because they just didn't have the resources to be able to care for these people. So thinking as an elderly person, geez, I'm old and I'm quite weak. God, if I get COVID as well, I might not even get any care. So it must have been a fairly traumatic experience for our elderly people all over the world. So what is actually frailty? One of the things which has been problematic in this area is that there is no standard universal definition of frailty. There are varying opinions on it, but they can't really come to a lot of agreement about it. And that has been one of the issues that has kind of like influenced research within this area, even in terms of interventions, the prevalence of studies, prevalence of frailty and things. But essentially what we do know is that it's a clinical state of reduced functional reserve. increasing individual vulnerability to develop negative health-related events when exposed to an external stressor. And that external stressor might be an illness, for instance. So the negative outcomes are things like cognitive decline, falls, disability, greater healthcare use, hospitalisation, potential admission to residential aged care, and increased mortality. The prevalence does vary depending on the study, and also that's, what kind of method of measuring frailty was used. But frailty, depending on the has been shown to be between 7 to 12%, depending on the population, increasing as we get older, so up to 26% in those over the age of 85. But probably what's really important to note is the people who are actually in the pre-frail stage. So these are the ones where potentially we've got a lot of scope to intervene, and we want to obviously stop in getting to that frail. It can be upwards of about 50%, up to 50%. So if we look at what happens as we age and our functional ability, so we've all got an inert intrinsic capacity. We've got physical and cognitive abilities which enable us to function effectively. And we function within an environment, be that our local physical environment at home or the greater social environment. Now, not everybody who ages will become frail. We can age successfully, which is hopefully what we should all intend to try to do by following a healthy lifestyle. But typically we have this usual trajectory of aging, which is not necessarily completely successful, but usually within the last few years of life, we start to acquire frailty, and then possibly maybe we might disability and death. However, accelerated aging is what we can often see in people becoming frail fairly early on. But we shouldn't necessarily consider frailty as an inevitable part of aging. And also, frailty doesn't necessarily mean that we will become dependent on other people. And that people who are physically frail may well still be able to actually function fairly well because other factors which are determinants of frailty might actually be in place. So we can think of frailty not just as the physical factors, and that is an area which has probably garnered a stack of research and predominates in terms of the thinking about what frailty is, but there are all of these other aspects that we need to consider. And many of these other aspects actually are considered determinants, or they're all considered determinants of frailty syndrome. And they're important because they actually help us to maybe cope with some of our physical deficits. And they might be issues which prevent us from getting to that disabled kind of like stage. So if we think about how we're going to assess for frailty, it needs to be multifaceted. Don't just consider a person's physical performance, but we need to look at things like nutrition. What's their cognition like? Mental health, what are their support networks like? Because most importantly, these are potentially the things which are going to protect against negative health outcomes and promote good well-being for us. So even though, we're thinking today about falls, we need to think about the other issues that frailty can actually result in. This is an interesting slide which kind of like extends that kind of like concept a little bit more. And one of the key things that it says is that frailty, yes, can be determined by lots of things, lots of biological risk factors that we consider, but also individual risk factors. There are also socioeconomic and living conditions, social and community networks, and this thing called resilience. Now, resilience is the process of effectively negotiating, adapting to, or managing significant sources of stress or trauma. And there are many advocates who actually say what's really important for us is that in our elderly population, it's probably important that not only are we looking at frailty, but we also look at the resilience and our ability to actually effectively cope with our significant stresses. If we think about this kind of like concept again, for falls, this has actually got quite a lot of kind of like relevance. We look at things like under social and community networks, living alone. That's a particular concern for falling people because if people live alone, if they're frail, they're at longer risk of a long lie. The issue of self-belief within resilience. So the self-belief that if you've had a fall, will you have another fall? Or are you confident enough to be able to actually regain and to do activities again? So this issue around fear of falling is often built within this concept of resilience and self-belief. We see in the biological risk factors, things like endocrine disorders which promote, so things like osteoporosis and increased risk of injury, cognition, which we know is linked to falls, sensory impairment. We know that at the key of balance deficits is a reduction in things like vision and hearing, peripheral neuropathy, vestibular disorders. And then this concept of sarcopenia, which we'll talk about in a minute as well. Things like physical inactivity, which results in muscle weakness and poor balance. That's an individual factor. So there's lots of, all of these determinants of frailty and our ability to cope with frailty or physical frailty as well, are really important in terms of thinking about falls. So physical frailty is that component of frailty which is probably being most widely studied. And there was an agreement that it's a medical syndrome with multiple causes and contributors characterised by diminished strength, endurance, and reduced physiological function. And this increases an individual's vulnerability for developing increased dependency and or death. So the classic frailty phenotype developed by Freed reports that frailty is unintentional, is measured by unintentional weight loss, fatigue, physical inactivity, slow walking speed, and muscle weakness. You need 3 of these components to be considered as being frail according to the physical frailty phenotype. The lower 2, slow walking speed and muscle weakness, are also representative of sarcopenia, which is a related condition to frailty. So there's 2 relevant related conditions that I wanted to include, and there's others in this scope, but there was 2 related ones which I thought was of benefit for us to review. Is sarcopenia, so weak muscle. So it's a progressive and generalized skeletal muscle disorder. It is actually considered a disease as opposed to frailty, which is a wider syndrome. And sarcopenia is associated with an increased likelihood of adverse outcomes as well: falls, fractures, frailty, and functional decline. So sarcopenia is commonly seen in frailty, not in all people with frailty, but they think roughly about 2/3. And it's characterized by low muscle strength, reduced muscle mass, and function. And the key thing here is around strength. It used to just be considered around muscle mass and muscle mass, but now strength is a really key component. Then the other component that is relevant for both falls and frailty is osteoporosis and osteopenia. So the issue of fragile and brittle bones. Obviously, one of the key things that we know that when people fall, if they've got osteoporosis or osteopenia, they're at an increased risk of actually having a fracture. Now, if we think about the relationship between falls and frailty being bidirectional, yes, frailty can contribute to people falling over, but if we have a fracture after a fall and we're not frail, then the immobility that results from having maybe like a significant hip fracture and maybe requiring rehabilitation for 6 to 12 months, it can certainly make us frail. So the relationship between falls and frailty can often be considered as bidirectional. Sarcopenia and osteoporosis can occur independently of each other, but they can also occur together. It's really important to think that early identification can help us to delay or prevent the outcomes of frailty and sarcopenia, and that these conditions may actually be reversible. And certainly the earlier we intervene, the better it is. Now, I'm not going to go into an explanation of the pathophysiology of frailty. This is not my strong point in terms of understanding this, but often what we see at a functional level, the background to this is really occurring at an organ-related level and a molecular level. Now, frailty can result from conditions such as COPD, renal disease, cardiovascular and congestive heart failure, but also from muscle conditions such as sarcopenia and osteoporosis. And the belief is certainly that at a cellular level, oxidative stress and greater inflammation is occurring. And really we're creating these, it really affects our ability to respond to stresses, both from a disease management perspective, but also from other external stresses. Now, just the presence of disease alone doesn't necessarily mean that a person will become frail. It may be that particular diseases are well managed and people are actually still functioning at a good level. But very often, once these conditions often accumulate, and over time, and with the addition of other lifestyle factors, it may mean that we move from an issue where we're actually quite robust, that we actually start to develop frailty. And this concept of low functional reserve starts to impede. And I always attribute it to, I always look at it from something I often explain to people with like a walking speed. So I measure walking speed when they're walking at normal speed, and I'll measure their walking speed, when they're walking as fast. And I always say to people, I want to see how you cross the road if there's a car coming. And sometimes what we see is that people who've got low functional reserve, they can't perform any quicker than they can perform normally. And this is pretty important because from a muscle point of view, for instance, the effort taken to get out of a chair or get off the floor can often be a maximal effort for that person, as opposed to being something that, we can do multiple times, for instance. The pathophysiology of osteosarcopenia is relatively common. Again, there are lifestyle factors, but there's also hormonal genetic factors which basically contribute to reducing muscle and bone. Essentially what we see, it's an imbalance between the catabolic and anabolic factors. So essentially the processes which degrade muscle and bone seem to be greater than the processes which are actually regenerating our muscle and bone. So how do we measure frailty? So frailty can be measured in a variety of ways. There's the frailty phenotype, which we've spoken about, but which I'll go through briefly again. A frailty index, which I certainly haven't used, I'm not that familiar with it. It's basically considered to be the non-specific accumulation of health deficits across multiple domains. So this is quite a detailed way of measuring frailty. And basically an index score is produced, which depends on the number of measures that are present compared to the number of measures that are assessed. It's usually assessed with maybe up to 30 or 40 kind of like particular components. And a person can actually develop their own frailty index, and there are rules around this. And then there are some other ones which are frailty indicators, which are some other common scales which we'll go through, which I'll briefly just expose you to, and then you can look at seeing which is going to be appropriate for possibly your work environment. So the Fried's frailty phenotype, this is the hallmark. So this is one which unfortunately requires a handheld dynamometer to measure grip strength. But otherwise, many of the other things are simply just weight loss, asking questions around physical activity, measuring walking speed, and looking at things like exhaustion. And the question for exhaustion, for instance, is how often in the last week, I felt that everything I did was an effort. And that's a simple, basically, way of measuring exhaustion. And then you ask a follow-up question on how often people feel that way. So this is a pretty simple way of measuring physical frailty, but the limitation is that you require a piece of equipment to do it. There are other ways of actually measuring physical frailty as well, which don't necessarily require equipment. So there's the Frail scale, which is a simple 5 kind of like point scale, and the soft criteria for frailty. Again, these are fairly simple kind of like tests which you can actually do, and potentially might be more user friendly. So looking at weight loss, for instance, in the soft criteria, energy levels, and then repeated chair stands. The Frail scale is a subjective assessment, so looking at the presence of certain conditions, the ability to walk a certain distance, go upstairs, whether the person has issues with fatigue and loss of weight. So again, these are a fairly simple way of measuring frailty. The other one, which is often reported, which again is very much a physical kind of like measure, is a short physical performance battery. And this is really just looking at balance, strength, and gait velocity. And in essence, this is maybe more beneficial in the sense of actually categorizing or assisting with us even maybe prescribing an exercise program. But it basically says it's a well-validated tool in terms of measuring performance, but it has been used in frailty studies as well. And that a score of between 4 and 6, the person would be considered frail. Clinical experience. So certainly one of the things is I bet that most of you would be able to identify a person as being frail just through a good subjective kind of like history and maybe some objective assessments that you utilise in your practice regardless of your profession. There are some tools which enable us to kind of like maybe tie some of this in a little bit more fully. So some of the questions that we would ask, for instance. So the Edmonton Frail Scale is another one which, particularly if we're doing a good subjective assessment, where we're looking at people's ADL performance, maybe briefly their cognition, what their general health is like, issues like continence, social support, you can get a score of frailty based on this. So there's two types. There's one which requires you to perform a timed up and go test, so a simple walk test of 3 meters, and another one which, the reported self version, which actually you don't need to do any physical performance measures, but you just have got questions around how people were able to perform 2 weeks ago. So 2 weeks ago, were you able to perform heavy housework? Were you able to walk up and down stairs to the 2nd floor without help, or walk 1 kilometre without help? So it's quite beneficial from that point of view, is that if you come from a background where you're not used to measuring physical performance, the Edmonton Frail Scale could be something that could be quite valuable. The other one, which is the Clinical Frailty Scale. Again, this is really quite detailed, and this often follows through maybe after a really comprehensive geriatric assessment. This is the one that's used in our Frail Rapid Access Clinic by the doctors and stuff after input from the multidisciplinary team. Again, really useful, can be used acutely, and there's a help guide which actually helps you use it. Both the Clinical Frailty Scale and the Edmonton, there may be license agreements that might be required as well with that one there, but you can check on the websites. The other one, which is actually, I've just came across just recently, and I actually thought was actually quite good, is the Sunfrail tool, which that doesn't score anything at all, other than actually just identifying some of the components of both physical frailty, psychological frailty, or social issues. And really what it does, it's a trigger to a user to potentially implement or refer on for further investigation if you're unable to do it yourself, but to really a prompt for a comprehensive geriatric evaluation. So I actually think that's possibly quite a nice little tool there. There are some references here which happy to forward to you just so you've got them if you need to find resources. In terms of sarcopenia, again, this is something which can be quite useful in terms of measuring. Some of the key things here is in terms of, we've got to find cases using a questionnaire, and then we assess muscle strength. Unfortunately, you can only confirm sarcopenia using fancy scanning equipment, which we don't always have access to, but we certainly can also measure how severe it is. So the questionnaire is actually quite easy to use. A score greater than 4 is predictive of sarcopenia. This is the SARC-F tool. Very simple questionnaire that you can ask, doesn't take very long. So it might be that you're able to do a questionnaire like this and some measures of strength and physical performance, and that gives you a rough idea, but you can't necessarily confirm it if you don't have access to scans. So falls and frailty are closely linked. And the relationship between them are bidirectional. But it's important to note that not all fallers are frail. So before COVID, when we were doing a little bit of QI, we looked at actually some of the data coming out of our clinic and just looked at a small cohort of people. And what we found is that about half of them were frail or vulnerable, and the other half were not frail. So these were all people who were still referred to a falls clinic. But what we did see is that there was quite a difference in terms of their physical performance measures, is that the vulnerable or frail group were slower and they were weaker compared to the non-frail group. So what's important here is to make sure that regardless of who our client is and whether they're frail or not, that we look at the risk factors for falling and maybe the circumstances of how they've fallen, and that we actually target those and get a good understanding for how they've actually fallen. Okay, so what does this all mean for falls prevention? I suppose the key thing is maybe we need to be looking at changing our practice or implementing frailty screening within what we do. And then we target the individual risk factors for frailty. Early intervention is certainly better, And frailty will have potentially an impact on how we deliver evidence-based interventions for falls. We spoke briefly about this before in terms of some of the various components, but we'll just skip over that. So we know that we've got a good suite of evidence-based falls prevention interventions that we can use. Exercise certainly being a key component, but all of these other ones are highly relevant. Vitamin D supplementation is believed to be very relevant in terms of the nutritional aspects of frailty management. And depending on other things, all of these are highly useful. For instance, the frail individual at home who's struggling with many basic functional tasks certainly would be considered an absolute prime candidate for an occupational therapy home visit, for instance. And multifactorial assessment where we're involving lots of different clinicians here. The interventions for frailty, which are usually, they're listed as being these. So comprehensive geriatric assessment, so using a team-based approach. Exercise, including progressive resistance training. Nutritional support, lifestyle modification, optimizing pharmacotherapy, building individual resilience. And for some, it might actually be about advanced care planning and end-of-life care if they're right down at the opposite end of that spectrum of frailty and into the disabled stage. So we do know that there's excellent evidence for falls prevention exercise to reduce falls prevention. We know that it should include a high dose of balance training, target both people in the general community and those at high risk, and exercise needs to be ongoing. We do need to incorporate strength as a component of that and walking, but it shouldn't be at the replacement of balance. So when it comes to exercise for frailty, we do need to think about who our client is. If our clients are robust, we need to really reinforce the importance of physical activity guidelines. Keep doing what you're doing for goodness sake, because it's going to help you down a track. And for our other clients, we need to move them towards this. However, we don't still have the optimal composition of physical activity programs for frail elderly people. So this is one way of proposing or thinking about it. What we do know is that we do need to consider a multi-component program. So we need to include balance, strength, aerobic exercise, but also things like power-based training and flexibility. So what we see here is that we've got our robust people on the right, so they can do things at a higher level. The pre-frail population is one that we really want to target. And then we've got our disabled and frail population here, and they tend to be ones where we need to do a little bit more strength. Balance is still important. So it's really making sure that if we're seeing a person who's frail and a faller, we just need to make sure that we don't forget about things like strength and building aerobic capacity. Aerobic capacity allows you to overcome those physical features of frailty like exhaustion, for instance. So we need to be building these up. And this can be a real slow burn. And that's one of the limitations that we can see in practice, that we might only have a small amount of time when we see a client, but these changes might take many months to achieve. There is a good paper which I'll allude you to, which is really just talks about how to be setting up a program and to think about maybe the length of time that we need to really be looking at programs. This was a study that came out, I think, of Spain, and they actually produced a protocol paper on how they really developed their exercise program. And this was really because they were basically not complaining, but they were indicating that there's so much research in this area, but nobody actually uses a standardized approach in terms of, a particular exercise program. So they kind of like provided a really detailed analysis of what they did. One of the interesting things that they found in their program is that after 4 months of detraining, so they trained for 6 months, after 4 months of detraining, a lot of the positive changes that they found, in particular with regards to muscle mass, and was actually started to deteriorate. And so what it really said is that we need to keep these programs ongoing, and we need to be able to facilitate that. There's some information you can get from ViviFrail, which was another way of maybe classifying people or thinking about how you would deliver exercise in this population. And they used the short physical performance battery that I spoke about before, and that based on the score of that, they would categorize people into the appropriate category and then they would have an appropriate set of exercises which they will commence people on. You can download this tool, and it might not be something that you necessarily want to use completely, but it might get you thinking about how you want to implement an exercise program if that's the area that you work in. It would be needless to say that nutritional supplementation is absolutely important, and we need to make sure that we're using the expertise of dietitians within the health system. We know that the quality and quantity of nutrients are absolutely essential to help promote good muscle health. And the research around this area, certainly from an exercise perspective, is that if you can add good nutrition to it, you actually get better outcomes. The evidence around nutritional supplementation alone is, however, uncertain, and they actually think that's more around methodological issues, not knowing maybe what the best nutrients actually are, and also that supplementation and maintaining that supplementation as we age can be really difficult. But making sure that also for us non-dietitians, and now certainly my knowledge of this area is, which is why I always tend to get dietitians involved in my patients where possible, is that what are the other barriers to effective nutrition? So remember those other determinants of frailty, those social issues, being socially isolated, not having access to a home care package for 12 months, for instance, that might limit the ability to perform shopping, or the difficulty with accessing services like that. All of these are kind of like issues which can be implicated in terms of frailty management. So one of the things that was summarised here, this is from an article just on osteosarcopenia, which just spoke about exercise and nutrition. And what they were really looking at was good vitamin, so resistance and balance exercise a couple of times a week, good vitamin D intake, good protein intake, okay, and a particular nutrient, leucine, which is really believed to be important for muscle synthesis, good calcium intake, and creatine intake. And these were believed to be key components with exercise that can help in terms of muscle mass and bone strength. But one of the things that was also noted by some authors in a recent paper, that there's a fundamental need to understand the optimal macronutrient and micronutrient mix that is advised for or offered to people with conditions such as sarcopenia, frailty, cachexia. Briefly, living alone, long-line frailty, make sure that we consider that people who are frail and live alone are at a big risk of a long lie, and this is really important. So we need to think about personal action plans and including technology if unable to perform floor transfers. So what's the link? So essentially what we have here is that Asclepius was the Greek god of medicine. Teosinote is the precursor to domesticated corn production from the Central American Indians back about 6,000 or 7,000 years ago. And beetroot obviously is linked to the Russians through borscht. So essentially what happened here is that the Greeks produced the first vibration machine, which they used to treat wounded soldiers. The developers of Kellogg's cornflakes, the Kellogg's brothers, developed the first whole body vibration machine and used that in their sanitarium. The Russians extended that through their cosmonaut program to actually develop whole body vibration machines, which they used to treat the deleterious effects of being in space. So the evidence around this is not necessarily clear, but certainly whole body vibration has been shown to improve bone mineral density, and there are suggestions that it can actually improve muscle strength and physical performance. And there was a small study which came out just last year looking at the use of whole body vibration in a population in residential aged care. Really small study, but it showed that it was actually well tolerated. And it may be that maybe interventions like this in the future need more research. So concluding up, falls are both an outcome and a cause of frailty in the older adult. If present, we should try to address frailty and falls together, look at the specific risk factors, and make sure that we don't forget what are those wider determinants of frailty that might impact the success of intervention. It's really relevant for the whole professional team to be involved. It doesn't matter who we are, there is likely for us to have a role within frailty management. And for some clients, they're going to need comprehensive geriatric assessment. Thanks, everybody.
Thanks, Tony. I'm just going to take the screen back. Yeah, thank you, Tony, for such a comprehensive presentation just then. You've provided a lot of really good options for some practical assessments that can be applied. And I think it's important for everyone to find what works for them in their setting as well. We've had Sandy Dumas from Fiona Stanley Hospital right in the chat box. They use the Rockwood Frailty tool, and they find that that works quite well for them. Please send any questions through if you've got any. We haven't received any. Oh no, sorry, we do have one at the moment. Actually, no, we haven't received any through. Please let me know if you've got any, and we can always send them through to Tony as well. So just to keep the conversation going today, Stay on Your Feet has got a range of different resources that are available for your clients and older adults, and these can be accessed through the Stay on Your Feet website. And just some next steps as well to keep that conversation going from today again. So we've got the Community Falls Network that we run, and this group aims to bring together a variety of different health and community professionals such as yourselves to discuss the key issues and share solutions together in community falls prevention. So our next Community Falls Network meeting is actually coming up quite soon on Friday, the 4th of June. So if you're not part of that yet and you're interested, feel free to reach out. We do encourage you to join that. We've also got our e-directory. So this is quite a practical and easy list of exercise programs that we have on our Stay on Your Feet website across WA for a variety of different fitness levels. And this is something that you can list your own class or assist your older adult clients to find a class in their local area. We've also got our Stay on Your Feet e-news. So this is a monthly e-newsletter that can help you keep up to date on any relevant information, research or upcoming events and trainings like today's webinar. So I encourage you all to sign up to stay up to date on that falls prevention information in WA. And I also just wanted to remind you that a survey will pop up after this webinar. So could you please take a few moments to complete this evaluation survey? It just really assists us to make sure that the training that we're delivering for you meets your needs. We've got a few upcoming events and training from Injury Matters. So something that's coming up in a few weeks, we've got the Understanding Family Carers Falls Concern and their Management of Older Adults Falls Risks. That's another free webinar that we've got that I encourage you to sign up to. Something else that I also just want to highlight, later this year, we've got the Australian and New Zealand Falls Prevention Virtual Conference coming up in early December. Abstracts are open now for that, so I encourage everyone to hop online and have a look into that as well. So that brings us to the end of today's webinar. Thank you all for joining.